Did you know that over 20% of lung cancer cases are of people who don't smoke? Oh, you didn't know? Well, it's true. Yes, I know you may be thinking, isn't lung cancer caused by smoking cigarettes? Oh yes, you're correct. Smoking is the leading cause of lung cancer, but it's not the only cause. People who don't smoke can get lung cancer too. There are other factors that cause lung cancer, like the fumes from the generator, the smoke from the firewood, radon gas, and many others. Be informed today, and let's talk more about this deadly cancer that kills more people than breast, cervical, and prostate cancer. Keep up with the conversation by sharing with your family and friends the risk of getting lung cancer.
Good afternoon, everyone. The month of November is a month where we have a few of the cancers that the world recognizes. This year, NMA, which is the Nigerian Medical Association, FCT, Federal Capital Territory Chapter, decided to do something about lung cancer in collaboration with MACA, Movement Against Cancer. And with us, we have, one of the really big names. And I'm so excited, that he's taking time out of his busy schedule. It's extremely early for him to join us this morning. Lung cancer is one of those forgotten areas, and we thought it important that we come together and, discuss this. I'm going to introduce Dr. Omonikoko, who is a thoracic medical oncologist who specializes in treating patients with lung cancer. His clinical interests include medical oncology, which includes diagnosis and treatment of cancer, hematology, diagnosis and treatment of blood disorders, and internal medicine, treatment of diseases in adults, essentially. He's the executive director of the University of Maryland, Marlin and Stewart Greenbaum Comprehensive Cancer Center, a National Cancer Institute designated cancer center. Now, for those of us in the oncology world, this is a big deal. He's also the Senior Associate Dean of Cancer Programs at the University of Maryland School of Medicine. In addition, he's the Associate Vice President of Cancer Programs at the University of Maryland, Baltimore. I've been to this center, it's huge. Dr. Omonikoko is a distinguished translational physician scientist. His research interests include preclinical experimental therapeutics, biomarker discovery, and translation of promising laboratory findings into clinical trials. He has received peer-reviewed extramural grant funding for his research from the US NIH and Department of Defense, private foundations, and pharmaceutical partners. Dr. Omonikoko is an elected board member and treasurer-elect of the American Society of Clinical Oncology, most of you know as ASCO. He's also an editorial board member for several highly regarded academic journals, including Cancer Frontiers in Oncology, Journal of Thoracic Disease, and Translational Lung Cancer Research. In addition, he's a member of the American College of Physicians, American Society for Hematology, Society for Immunotherapy of Cancer, and International Association for the Study of Lung Cancer. He has been a National Institutes of Health Studies section member for over a decade. So ladies and gentlemen, we have those who write the literature with us, essentially. We have someone who can answer all the questions and also has the advantage of not only being Nigerian, but he has the knowledge from both sides. So today we're hoping that he's going to be able to share with us, some really major insights and, things that will help us have this conversation going so that lung cancer doesn't just remain a myth for us in sub-Saharan Africa, but, something that we are able to diagnose, treat, and give our patients the best. Dr. Omonikoko, or Professor Omonikoko, sorry, you're welcome.
Thank you so much, Dr. Shagai. Good afternoon, everyone. Honored to be part of this panel.
So this is an NMA event. As usual, Nigerians, we tend to be a bit late. So we're going to just, dilly-dally a bit, but we will definitely get to the meat as we go along.
Sure.
This is wonderful. Our chairman is here. We didn't think he would be able to join us because he's actually in the field right now. I have Dr. Emeka Oyogo, the chairman of the NMAFCT. Please, sir, you're welcome.
Thank you, ma'am. Good afternoon.
Sir, the floor is yours. Please, you can declare.
Dr. Nini, Professor, I salute all of you. Good afternoon. Good afternoon, sir. Thank you so much.
Good afternoon, sir.
Yeah, sorry, I'm coming late. I'm from somewhere. I have to come and serve because there's no service there to see how I can be part of what we are going to discuss today. Thank you for everything. Thank you so much.
Thank you.
Thank you. So, Prof, could you just tell, because I have medical and non-medical people in the house, could you just, briefly tell people what is lung cancer before we go into the real nitty-gritty?
Yeah, thank you, Dr. Shagaya. Thanks, everyone, for joining. Hopefully, everyone can hear me well. And it's, as we all know, November is Lung Cancer Awareness Month. And around the globe, different organizations, societies, groups are coming together to shine the light on what lung cancer truly represents. I think we all know what cancer is. And in short, cancer is just a disordered growth in the body of tissue that can no longer be controlled. And when that happens, it can continue to grow and get bigger in the same location, or it could move to other parts of the body. So when you think of cancer that way, it can happen at any point in time in any part of the body. And depending on where it's starting from, that is how we name it. So cancer that's starting in the lungs, we call it lung cancer. If it starts in the breast, we call it breast cancer. If it starts in the colon, we call it colon cancer. If it starts in the muscle, we give it a different name that's also cancer, but it sounds more complicated when we call it sarcoma, but it's just a form of cancer that's starting in the muscle and the soft tissue. So with that, any type of cancer that starts primarily in the lung, we call it lung cancer. That is not to be confused with cancer that started in a different part of the body and then moved into the lung. We do not call that one lung cancer. We just call it by the primary site where it is coming from. So when you think about that, people diagnosed with cancer of the lung, meaning primary cancer that's starting in the lung, globally is a very, very big problem. And depending on which region of the world you live in, it could be the number 1, number 2, or number 3 in terms of cancer diagnosis, and oftentimes number 1 or number 2 in terms of cancer death. So here in the US, for instance, almost 250,000 people, 235 to 240,000 people, will be diagnosed with lung cancer annually, newly. And globally, that number is more than 1 million. Majority of that now is shifting from the Western world to the low to middle income countries, especially in Asia and other African countries. So I will stop there for now, and then happy to take more questions.
You just said something that caught my. Why do you think this shift is going on?
So why do we observe this shift in terms of prevalence of lung cancer? I think there are probably several factors that people would adduce as being responsible. Oftentimes what we think is going on may not necessarily be the reason why what we are observing is taking place. But there are proven factors that we know predispose people to development of lung cancer. Tobacco use, for instance, is one of the strongest risk factors for anyone to develop lung cancer. And it's not just taking a puff of tobacco and then stopping. This actually has to do with long-term chronic use of tobacco, especially inhaled tobacco, that causes a lot of damage in the lungs and causes a lot of inflammation. And then over time, the tissue of the lung will become maladapted. And that maladaptation to the injury that the tobacco is causing can get out of hand. And that is what will become lung cancer in those patients. And when you see patients who develop lung cancer as a result of tobacco use, in the past, we know there's been some changes in terms of the appearance of the cancer under the microscope. So when you look at it in the, say, in the late 50s to 70s to the mid 80s, the preponderance of cancer that you see associated with tobacco in the lung tends to occur in the central part of the chest, what we call squamous type lung cancer. Then something changed. The introduction of filtered cigarette, whereby you have a filter at the bottom of the cigarette stick that you are now sucking the air through, means that the bigger particles of tobacco are no longer able to get through that filter. So you have now finer particles of tobacco and all the chemicals in tobacco being inhaled. And because they are smaller, now they can travel further into the lungs. So over time, there was a shift in the type of cancer that we observed in people who use tobacco from squamous to what we call adenocarcinoma. So that was a well-described pattern of change in terms of the appearance of the cancer under the microscope that is related to how people are using tobacco products. What we've now observed 30 years later is because of all the tobacco control effort in the Western world and part of Asia, but unfortunately the rest of the world really do not have any organized structure around tobacco control. We've observed that in the West, and especially also in Asia, that the proportion of patients being diagnosed with lung cancer who never smoked is actually the highest rising group within patients diagnosed with lung cancer. Currently in the US, about 20% of our patients would be diagnosed with lung cancer without having ever used tobacco products. And they tend to be younger in general. If you go to India, China, and Japan, that proportion is about 40%. So 40% of their patients will be diagnosed with lung cancer without no objective documentation of having been exposed to tobacco smoke. So with that, you now see a change in the demographics, number one, but also a change in the distribution of lung cancer between countries across continents. That where they used to have tobacco-related diagnosis of lung cancer, that is coming down because of tobacco control effort being successful. And let us realize that even if you were to start tobacco control efforts today, you're not going to see that benefit for at least 15 years. But that is how long it takes for your body to repair whatever harm has been done. But that's also how long it takes if you pick up tobacco today on average for you to see that influence the rate of diagnosis of lung cancer. So everything takes time, whether to cause the damage or more importantly, to induce the repair. So that is the reason why the incidence in the US and other Western, at least in the US, and part of the Western Europe is going down. But then when you look at Asia, the tobacco use is also going up. There's no tobacco control effort. And then in addition to that, you have this rising incidence of patients developing lung cancer without actually ever using tobacco. And I think you're probably going to see a mixture of those two patterns in Nigeria as we continue to learn more about the distribution of the cancer in Nigeria and who have been diagnosed with it. I think we're going to eventually see how this pattern would evolve over time as well.
Thank you, sir. So right now, do we really know what the burden of lung cancer is in Nigeria?
I think we have very, very qualified people here on this panel to help answer that question.
Because,
yeah.
Because when we look at the literature, it's very, because I've looked at, we're gathering the data, and what we're seeing is very different in different parts of the country. Yes.
So I think the honest truth is that data is very, very difficult to collect anywhere, whether it's Nigeria, whether it's Namibia, or whether it's Norway or Nicaragua. It's very, very difficult collecting data. And different approaches have been explored. None of them is perfect, but you have to combine multiple approaches. So the most reliable data tend to be a combination of population-based monitoring along with facility-based records. Facility-based records tend to be easy to collect, but it doesn't necessarily represent the broad population of people living in that area because you only see those who come to that facility. So it doesn't reflect the entire population that you serve. But it is very easy to collect because they already came there, you made the diagnosis, and then hopefully you keep accurate record of those patients coming. So at least you can use that to now project, wrongly or rightly, but at least that is some data that you can have. When it comes to population-based registry, that is much more expensive. It requires a lot of political and economic will. And it also it requires for people who are in decision-making positions to recognize the long-term benefit, because it's not something that you set up today and you're going to see the benefit that you can measure tomorrow, however you want to measure it. But not having that data actually imperils any type of planning that you want to do. Because how do you allocate resources if you don't know what you're dealing with, if you don't know the burden of the problem that you want to address? So there are places where this is done very well. There are places where people struggle, and there is nowhere where it is perfect. The little I know, most of the data coming out of Nigeria tend to come from facility-based registry. You know, the pathology department will have their data, and then you collate that, and then you can then, based on that, make some projections. We do not have a population-based registry where, regardless of where you're diagnosed, that information is tracked. It's required that you submit it, and then you can now look at where people live, where the diagnosis, regardless of where they go for the diagnosis, you can at least track them back to their primary area of residence, and then use that to now project how many of this type of cancer do we expect based on what we've seen in terms of the number of patients living there and number of patients diagnosed with lung cancer. But the data out there, whether perfect or imperfect, would suggest that if you look at the lung cancer burden in Nigeria relative to other African countries, I would say it's probably significantly underreported, number one. So we have to take that with a grain of salt, whatever we have out there. But the little we know is when you look at the distribution of the type of cancer, and I think the most recent data out of Nigeria that I could find in preparation for this engagement was actually the one led by Dr. Okonta and Dr. Jima, where they sort of tried to look at facility-based data, and the distribution that they reported would mirror what one would expect, meaning majority of the cases were adenocarcinomas, followed by squamous. They had some small cell and then some large cell. So histologically, it mirrors what you will see in other countries. What we do not have is, these days, we don't just look at lung cancer and then we say, oh, it's adenocarcinoma, it's squamous, it's this or it's that. You have to go a little bit further in terms of characterizing those tumors with respect to genomic alterations that could be the driver. So if you have a patient who never smoked and developed lung cancer, your job is not done by just saying it's lung cancer. But those tend to be patients where you may have genetic alteration within the cancer cells that is driving the growth of the cancer. Unfortunately for those patients, nowadays we now have approved drugs that will specifically target the genetic alterations that is driving the growth of the cancer. So not having that information, I think at this point, is a great impediment to optimal care delivery when it comes to lung cancer management in Nigeria. The other thing that I would also point out is oftentimes we do not have access to some of the diagnostic platforms. And when you do, it can be very, very expensive. So not having the mechanism in country for the cost of healthcare to be shared across the entire population in terms of insurance, because that is really the concept of insurance, is you spread that burden across everyone, because you don't know, anyone can be sick, but not everybody will be sick. So everybody carries part of that burden, so that those who actually now fall sick would have something to support them. So not having a very functional and well-integrated insurance system is also a big challenge in how you can make this happen. Because even here in the US, if you're not insured, some of these tests are so expensive you cannot afford them. So I can only imagine if you have to send that type of tests either to South Africa, to Europe, or to the US, you are still going to have to pay that same amount of money that we will pay here, because there's no free lunch. And people here cannot even afford to pay for it if they do not have insurance. Talk less of somebody, maybe minimally insured or uninsured from Nigeria, and you're asking them to pay $6,000, for one test that may actually come back to be positive, but then you may not even be able to afford the drug. So these are all the complexities around. It's not just enough to say, oh, the test is there, go and do it. You have to think about it holistically in terms of, you do the test, where are you doing it from? What do you do with the result? And can the patient afford whatever you're going to recommend for them when you have that result? While it may sound complicated and impossible, I think if we put our minds to it as a society and we come up with a plan and a strategy, it's doable. Other countries with same level of resources as Nigeria, they may not be as big. They may not be 220, 230 million, depending on what the number is this morning. But they have also figured out a way to bring this type of expertise in. Brazil is one typical example where, population size wise, they're comparable to Nigeria. Economically, maybe they're a little bit better, but it's not like totally well off than what's going on in Nigeria. But at least they have a mechanism in country where a significant proportion of patients will be able to access this test and then the indicated treatment if the test were to come back positive.
Well, I'm listening to you and my mind is, churning. And I'm thinking, when it comes to policy and being able to make a case for insurance, because we've got a national health insurance scheme. If we don't have our numbers, it's difficult to make a case. And I'm just hearing you and I'm listening to you and I'm asking myself, what do we do? Because AstraZeneca has just launched something a few months ago where patients are able to actually get their EGFR driver mutations tested. Mm-hmm. I remember once upon a time when we were starting to use Taxotere by Sanofi, it was costing millions. Mm-hmm. But as we started doing immunohistochemistries and started using those drugs, we're able to drive down the cost down and we're able to have better access. And it became a household drug in the oncology clinic. And I'm thinking to myself, we probably can do the same thing in lung cancer space. Mm-hmm. So I think we here, need to do our homework, get our numbers, know how much of a burden this is in Nigeria, and then be able to drive that policy where NHIS is able to help to, like you say, share the cost across, everybody. If the farmer is willing to already start to help to do the test for free, at least that takes off a little bit of the burden financially. But I think we really need to start and do it quickly. Have our numbers. Because of the stigma, I think there's that somewhere at the back of the minds of even the patients themselves, especially the ones who are smokers. It's like it's a punishment for having smoked. So the advocacy in lung cancer in Nigeria is not strong enough. But with meetings like this and discussions like this, I'm hoping we are going to be in a better place. Next year, come November, when we're having this discussion, we'll already have our numbers. We'll know, how much of a burden is this. We'll be able to say under the NHIS, lung cancer patients are taken care of, at least, up to some level. So I hear you loud and clear, and I'm hoping the other people, who are in the lung cancer space, because most of the people we have are really people who are really interested in lung cancer. Lung cancer isn't like breast cancer, where everybody will be part of that discussion. It has to be someone who is quite passionate about it, to take time off their Saturday afternoon to have a discussion. So, Prof, I'm just wondering, I'm practicing in Nigeria, LMIC. If there was someone an LMIC, I would belong to that category. Is there anything, really unique to the doctors here that when you think about how we practice vis-a-vis how you practice, is there anything that strikes you? And is there anything you think we can do to make it better in context of how we are practicing?
Yeah, I think if I just limit myself to what I know and not dabble into what I don't know, which is very, very easy for all of us to sort of get onto that slippery slope. So lung cancer is what I do, and that's all I know. So I don't do anything else. I think I really respect our colleagues practicing in Nigeria because when we deal with issues here, we say this is too hard. And the demand is enormous. The patient wanted to do this, the patient wants to do that, the hospital wants to do this, the clinic requires this and that. And I would just put myself in the context of what you are all doing in Nigeria, where number one, the care is fragmented, the expertise is there but it's not coordinated. So it's possible that the patient will have to go to a facility for the diagnosis to be done and maybe go to a different facility for the treatment. And then once they're out of your facility, there's no way for you to even know what is going on with that patient until they show up the next time or they never show up. So you are operating within this vacuum in terms of system support. And there's just not a lot that you can do. You can do a lot as a single person, but when you are thinking of impact at the societal level, without that coordination of effort, there's just limited amount of people that you can rely on, that everybody will do the same thing to the same degree and then put in the effort day in, day out, no break, no rest. Now, having said that, I'm recognizing that as a major challenge, that we do not have an organized support system, both for the physicians, the nurses, and all the other experts taking care of the patient, as well as outside of the facility in terms of, other support that the patient might need. What I see as the major difference between the way we practice here and the way we practice in Nigeria, I think is, number one, the system itself, the way we are organized in terms of practice. Our healthcare system is not linked. So if somebody were to come to National Hospital and they go somewhere else, it may not be that easy for them to know what the National Hospital team is doing to, take care of a problem. And they may have to start from the beginning. So they actually lose the benefit of whatever effort, expense, time, energy has been devoted to that patient when they went to the original facility. Now they're showing up somewhere else. So that is one. So the second is that by doing that, you are also not getting the biggest bang for your buck. Meaning, for the amount of money and time and energy that you expense, the readout is actually minimal because you're having to repeat all these tests without that system approach to what we're doing. So I would say that is probably the number one thing that I would say is the difference between the way we practice here and the way you practice in. And it doesn't mean that we're perfect here. There are systems here too that are not linked, but at least you can track the information down in terms of what the patient has gone through. And the patient are also well informed that they're going from one facility to another. They know to ask for their record. And that is made available very, very easily. I know that in certain facilities in Nigeria now, that is becoming easier. But for the vast majority of our people, they go to facilities that for you to even get your record, you may have to, beg and prostrate and do all sorts of things because everybody is busy trying to do something else. and you come in to tell them you need your record from 6 months ago, they will look at you like, that is not the top of my priority now. So I would say the system approach to doing things is probably one area of challenge. The second is, we have all this network of state hospitals, whether you look at it at state level or federal level. And I see those as actually an easy, not easy, relatively speaking, a point of convergence, where if you are able to link all those facilities together electronically in terms of their record, you'll actually start creating a platform from which you can now grow. The last part that I would say in terms of how we practice here and there is we also have a lot of private practice doctors here, but oftentimes your practice is linked to a hospital. Whereas in Nigeria, we have all these, standalone, to God be glory hospital, who cares medical center, don't come to me next year hospital, right? Each one trying to do their own thing, and there's really no linkages between them and the bigger facilities where a patient may go if they have, much more complicated medical issues. So those, I would say, are the most glaring differences. And it's very easy to just jump to technology to say, oh, we have this, you have that. I think technology to me is a tool. You can always acquire the technology. The question is, what is the impact of that technology when you acquire it? And so without creating a system and a platform that allows you to leverage whatever technology you bring into the system, I think the impact is always going to be much, much more limited. And people work a lot harder than most other places. I remember my time in Nigeria too. You have your primary location of work, and then you're, doing some other things all over the place. That is also is a big distraction. And those locations where you practice may actually not be in any way coordinated or connected. So now you're going from one place on Monday to a different place on Tuesday to another place on Wednesday, and you have to recalibrate your brain in terms of what you're trying to do. So I see that as really the biggest impediment to optimal care delivery, not just for lung cancer, but for healthcare delivery in general. Specifically talking about lung cancer, I think we've mentioned something about the diagnostic. The other aspect of it that I think could be challenging in our own environment there in Nigeria is what else could look like lung cancer? And how do we sift that, from cancer? Oftentimes the tests that you have to do, that they tend to be invasive. Whether you're thinking of percutaneous biopsy or even endoscopic inspection and biopsy collection, they are quite costly. So there could be delay in diagnosis being made. And we have all sort of people, trying to claim to know what they're doing and offering, suggestions to patients as to what is going on with them. Going from trained people, but who really don't want to stay in their lane and they dabble into things that they don't know, to untrained people who just, give themselves the qualification to weigh in on whatever the patient is suffering from and start dishing out treatment to them that may have, at the end of the day, perhaps make the patient's situation worse rather than better. So those are all areas of difference and opportunities that I feel, if properly addressed, understood and then addressed, perhaps will help a lot in elevating the care that we provide to those patients.
Thank you, Prof. I'm enjoying listening to you. I could go on for just listening, The audience, please type your questions, in the chat box, because you're not going to get this chance to catch Prof so easily and so, so please write your questions, in the chat box. Prof, when you talked about other diseases that could be distracting, being in West Africa, for some funny reason, or well, it's expected, but the general physician has tuberculosis in their mind. I've seen patients who all the TB tests are negative. Or for some funny reason, the physician decides to still treat for TB. And
Yeah.
I'm sure, I don't know if we haven't checked that much, if COVID too has also not made it any easier.
Mhm.
What is your take on that? Tuberculosis, lung cancer in TB endemic areas.
Yeah, I think like they always say in medical school, right? Common things occur commonly, and the uncommon presentation of common things are still more common than uncommon things. So, if you live in an area where infectious processes are very, very common, it's reasonable to assume that the patient in front of you with a constellation of symptoms like that probably has an infectious process, whether it's tuberculosis, whether it's, common acquired community acquired pneumonia. But where we shouldn't become lazy and where integration of system becomes important is when your diagnoses don't line up. Then you have to question your diagnosis. You cannot be dogmatic and say it has to be TB, and then you are treating the patient. Even when you cannot, you have to convince yourself that your diagnosis is right. At times what you have is people making diagnosis through treatment. Like, if I treat you and you get better, then my diagnosis is right, which is absurd and opposite. The first thing, you make your diagnosis and then you treat, not that you treat and then you say, oh, the patient responded to my treatment, therefore that must be the diagnosis. At times, health problems can resolve on their own without you doing anything. So the fact that you did something and the patient got better does not prove that your diagnosis was correct to start with. So that is one. The second is, it is also possible for somebody to have tuberculosis and on top of that to have cancer. So it doesn't mean that somebody coming with what looks like pneumonia could not have something else that is predisposing to them developing pneumonia. Like I mentioned in the beginning, when patients used to have a lot of central disease, and oftentimes what they will present with would be what would look like lung abscess, because you have something growing, causing a blockade, and then you have infection that becomes chronic problem. Now, when that patient is presented, everything will look like infection. And of course, there is infection. And then you treat them and they get better because now you are treating the epiphenomenon. What you are not treating is the primary process that led them to develop the pneumonia and then the abscess in the first instance. And it is possible, maybe that patient came to National Hospital or another hospital in the city and they got better and then they went back home, right? Usually what you need to do for someone like that is you have a follow-up imaging to show that everything has resolved. And at times that is how we pick lung cancer, even here. Like, somebody presented like classic pneumonia, you treat them, they got better, and then the follow-up x-ray or scan will show you that there's still something there that is persistent. And then you have to start asking yourself, is that just scar tissue or is this something else? Then you need to work that one up to know exactly what it is. And that could be how you then pick up that patient diagnosis. So not having a system approach to what we do also means that those patients you are going to miss in terms of early diagnosis of their cancer. And then the third aspect of this is waiting for patients to actually develop symptoms before you make the diagnosis is the worst way possible to make the diagnosis. So understanding those who are at risk of developing the cancer and then having a way of screening them to detect the cancer early before it actually shows you symptoms. But when you think about lung cancer, 65% of them will be diagnosed at what we call the advanced cases of lung cancer. 45% of them would have metastatic disease, which is not curable. So if you wait until someone develops it and they present at that stage, you are now playing catch up. Whereas if you catch them early, when it is stage 1 or stage 2, those are curable diseases. And there are interventions that you can, at the current time, deploy to make sure that that type of patient will not have recurrence of their disease, because that is the other challenge. Even if you catch it early, there's a relatively high rate of cancer coming back, either the primary one that you treated, or for somebody who smoked, the rest of the lung is still a high risk area. So they could develop secondary lung cancer following their initial diagnosis. So you have to follow them and monitor them. So those are areas that I would say, yes, you can have tuberculosis confusing the diagnosis, but at the back of our mind, we always have to recognize that there's nothing that stops someone with tuberculosis from also having another problem. You have to make that diagnosis first and not just say, okay, I treat the patient gets better, therefore they have tuberculosis. And the third is, even after treatment, we have to make sure that everything is resolved. And if in doubt, if something doesn't add up, now it's easy for me to say this here, just get a biopsy. I know that that's almost like moving a mountain in the context of what we do in the country, but let's remember that now there are also blood tests that you can use even for the diagnosis of tuberculosis, right? That could at least help tell you whether your reasoning is correct and your differential diagnosis is appropriate. We have to all go back as we have trainees coming through us. I think at least one area that I know I was deficient in, coming from Nigeria to practice here, is our approach to differential diagnosis is not the best. So we always start with, I already know what the problem is, and then I go for it. Oh, the patient is coming with fever and they have some of these others is malaria. I don't need to do anything, right? And maybe given the context, maybe 60%, 70% of the time you will be correct. I said, well, who cares? The 30%, yeah, we'll figure it out. But if you have the same approach from the get-go of do not ask what is causing the problem for the patient, ask what can cause this problem. So you start out with a very, very broad mindset, and then you get additional information to then narrow it down to what you think is actually going on with the patient. I think we do a lot of good service to the patient that we care for.
It's obvious you're a teacher. I'm listening to you and I'm enjoying myself. I hope the participants are having a good time the same way I am. So speaking of, do you think Nigeria is ready to start screening for cancer, for lung cancer? Considering that we don't even know what our burden is. Do you think what
so
would
is
be
Nigeria ready?
Do you think,
I think
we're having these conversations now?
Yeah.
We should, I'm thinking, I'm going to take my takeaway from here is I need to know what the burden is. And, when you want to defend or justify why you should screen for a disease, why you want to catch it early, it has to be it has to be a problem.
Yeah.
But from your own experience in your own setting, screening the at-risk population has helped you find those patients early. Do you think it's something that we should start thinking about?
Yeah. So I think I will answer that question in two ways. One is what should be done and what can be done if we are talking about today, because I would say lung cancer screening should be done. That should be on the table, right? But what can be done today is a completely different question. I don't think realistically we can start talking about lung cancer screening in Nigeria today. But if we recognize that this is something that should be done, then we start planning for it. And part of what you're talking about is what will go into that planning. What is the burden? What problem are we trying to address? And what is the best way for us to address it, right? So if you think about lung cancer screening, even here, the most effective tool that we have now is low-dose CT scan. We know that if we do it properly in the appropriate population of patients who are of the right age, older than 50 years, they've smoked for more than 20 years, and they've stopped smoking within the last 10, 15 years, or they continue to smoke, we know that when we focus on that population of patients, we are likely to find the cancer in them at much earlier stages. And when you do that, the benefit is actually just as good, if not better, than the most expensive drug that we use when you catch it much later on. So that is proven. But even here where we have that tool, proven, do we use it? No. So across the US, the average screening rate for the at-risk population is around 12%. Okay? In some states, including where I am, that number is less than 10%. So even in places where I've described, oh, we're organized, we are connected, we are this, we are that, screening is very, very challenging. It's capital intensive, labor intensive, time intensive. And oftentimes, even facilities where you want to go and do the screening, they may not have the capacity or the throughput for everyone to be screened the way you want it to be done. So you now have to start getting creative. No, so people now explore maybe mobile screening van so that you don't have to go into the facility and then clog up their system, right? People are exploring, can you use blood tests that can tell you, okay, this person is at risk, and based on this blood test, we think they're probably at a much higher risk, and therefore they should be the one that you screen. So there are a lot of implementation challenges around screens. That's why I don't want to just jump, oh yeah, we should be doing it. Yes, we have to quantify the problem, know the scope, and by getting the data, you may also realize that maybe your problem is not where you think your problem is. That perhaps majority of people living in the rural area, they don't smoke, they don't have environmental exposure. You don't have a lot of people being diagnosed with lung cancer in those areas. But maybe it's only those living in the urban congested cities where you see a lot of the problem. Then you can now tailor your screening effort to where the burden of the problem, rather than say, oh, we want to have nationwide screening program, let's screen everybody and all of that. That is going to fail. So getting the data, scoping the problem, and then applying cost-effective way of doing it. And part of the reason why we are now trying to develop blood tests, even here, is because we know just deploying CT scan for everyone is not viable. The capacity is not there for you to do that on schedule at the right time for everyone. So if there's a way for you to further refine those that will need the screening, who are maybe at a much higher risk than just their smoking history and their age, that could help. The third is the political will has to be there. If you have the simpler your tool for screening, the easier it is to be adopted. Now people don't look at, I talk about the adoption of low-dose CT screening as under 10%. But if you look at the same thing for colonoscopy, it's almost 70%. If you look at it for mammography, it's about 90%. So that is because people recognize this as something that is important, and they've come to identify the procedure that you need for screening as easy in their mind. So they do not see that as a barrier. Whereas when you want to do low doses, immediately people think, oh gosh, it's another scan, they have to go somewhere else, and things like, so you already created that barrier in people's mind of what is going to take for this to be done. Now, when you look at the benefit from lung cancer screening, and you compare that to the benefit from colonoscopy or from breast cancer screening, you actually get better value, better impact with low-dose CT screening. The number of patients that you need to screen in order to make one diagnosis of lung cancer is somewhere around 200 to 300 patients. For colonoscopy, it's about 600. For breast, it's about 700. So you actually have to screen lower number of people to make one diagnosis of lung cancer versus what you have to do to make an equivalent number of colon cancer or breast cancer diagnosis. But despite that, we screen more for colon and for breast. We screen less for lung cancer. So it's a tortuous way of answering your question, but I would say that screening should be part of what we want to do, but it has to be systematic and not just be a knee-jerk reaction of, okay, now there's screening, let's go and start doing screening.
Heard you loud and clear. Now, before we begin to round up, because we don't want people to get bored, Prof, could you just tell us, some of the common lung cancer myths? You've been in this lung cancer space for a long time.
Yes.
What are some of the common myths that you've heard, come across in your practice, and you also know exist in our practice?
Yeah. So there's myth everywhere, and it's not limited to just the patient. There's actually myth amongst physicians themselves. So the first myth I want to dispel, and this is amongst physicians, we always joke that there are only two sets of physicians who believe in chemotherapy. They're the oncologist and a physician with cancer. Every other physician, they don't believe, say, oh yeah, it's poison. Oh, don't give it to me. Oh, that. But then, God forbid, but if they come down with it, they'll be like, where is that chemo? Which one do you have? Give me the strongest, right? So that's why we always joke there are only two groups of physicians who believe in chemo, the oncologist giving it and a physician with cancer. So there is the myth, even amongst medically trained people, about cancer being a death sentence. And don't waste your money, don't waste your resources treating it. Just let the patient go. So that nihilistic approach, I think I've observed it amongst a lot of medically trained people. So that is one myth. Yes, there was a time in the past where lung cancer diagnosis is a sure death sentence because people were being diagnosed very late and there was nothing to treat them with. And we're not talking of 100 years ago, right? You are talking about docetaxel. So docetaxel was approved for use less than 30 years ago. 40 years ago, there are only two drugs that we had to treat lung cancer patients. And once you've tried those two and nothing else is working, the patient would have to go to, palliative care and hospice. So a lot of people who trained in that era where there was really nothing to help the patient with, and they've not been exposed to the field, they just carry that forward to say, oh, don't let them mess around with you. There's nothing really that they can do. Now we have patients with advanced stage lung cancer living with that disease as a chronic problem. 25 years ago, the median time from diagnosis to death for a stage 4 lung cancer patient was about 6 months with the best treatment that you can offer them. Now that we know there are a subset of lung cancer with specific targeted therapies for them or immunotherapy, there are now patients with stage 4 type lung cancer living 5, 6, 7 years on average and continuing. So I think we have to educate ourselves, and it's good that you're doing this type of program, that getting a cancer diagnosis does not necessarily mean absolute, in absolute terms that the patient is going to die from the cancer. We should encourage them to at least seek care from the appropriate location in a timely manner. So that is one myth. The second myth from the patient perspective is, and especially in our hyper-religious environment, of people saying, I reject it. You really cannot reject what is already there. You may want to just, do everything that you can. What you have to do it. Let God do his own. So God is there to do what he's going to do, but we also have to do our own. So the myth of I cannot have cancer, it's not in my family. Nobody has ever had it. That is not me. I reject that diagnosis. I think we have to help people to understand that. The other myth, and I don't know how prevalent that is actually in Nigeria, but I've seen that here, is people believing that if they do surgery on you, your cancer will spread. Okay. That is also a carryover of the era when there was not a lot of technology to help us to know what we're doing. Yes, there are stages of lung cancer that should not be operated on. If the cancer has spread, putting patient through big surgery is not going to make the outcome better. In fact, it will make it worse. So there are stages of lung cancer where we would not recommend someone to go through surgery. But in the past, when we did not have the tools to know the full extent of the disease before going to surgery. That would be when you think maybe something is stage 1 or stage 2, and then you go in, and then it turns out that it's already spread. And then you come out and tell the family, sorry, it was much more advanced than what we thought. It had already spread. So that myth got carried to say, oh, once they open you up, it's going to spread. Don't agree to surgery. So that is another myth that we need to combat. And then the fourth one is about the risk factor, which is people believing that, oh, I've smoked all my life, nothing has happened to me, who cares? Yes, it's not everybody that smoked that is going to get lung cancer, but majority of people coming down with lung cancer have smoked. So that's actually how that association was made. So people should not poo-poo the fact that what we know to be the strongest risk factor does not apply to them. So the sooner, the better. And it's never too late. Someone can say, oh, I've been smoking all my life. It's too late for me to stop now. We know, even if you smoked before and you stopped and you later develop lung cancer, you are better able to tolerate the treatment that you need. And therefore, your outcome is probably going to be better than if you continue to smoke while you were diagnosed and while you were going through treatment.
Thank you so much, Prof. I'm enjoying this discussion, but we have to look at the clock. We have some questions and some comments. I'm going to just look at the participants. Dr. Ayuba, maybe you should look at, are you there? Okay, so
Yes,
can you go through some of the questions? I'm not able to see. Okay, let me see okay, let me see if I can see. We have some.
There are 3 questions in the Q&A.
Okay, so maybe we can take the first question and let's see if, because some people might want to have some people might want to have some comments. It may not be questions, but take the first question and let's discuss it.
So I think the first one is from Dr. Opanga. Do you think that setting up a facility-based multidisciplinary tumor board could improve the patient care? Oh, that's it. Thank you for asking. That's a soft one. Absolutely. So taking care of patients with lung cancer requires expertise from many different angles, right? You need the surgeons, you need the pulmonologists, you need the pathologists, you need the radiation oncologists, you need the clinical oncologists, medical oncologists, nutrition, nursing. So there is a lot that will have to come together to help that patient. And working in silos has been shown not to be helpful to patients. So multidisciplinary tumor approach to a patient that is newly diagnosed is the best way around it, so that everybody is talking at the same time about the same problem, and you all come to the resolution and conclusion as to how best to treat that patient. So absolutely, if you can, that's what I will encourage you to do, especially if you have the core group of expertise and your center is known to provide that type of care, that you really set yourselves as a multidisciplinary group to give the best care possible to the patient.
Thank you, Prof. Dr. Yuba, the next question.
So we have some survivors that have been trying.
We have some survivors who are online.
To log in. Unfortunately, I don't know. She said she's somebody who has been on chemo. She has had chymotryxia and cisplatin. She has had up to 7 courses. So she wants to ask Prof, why is she adding weight? She said she noticed her abdominal girth is increasing, even though we've given her explanations, but
is she able? She's not
she
able
wants
to come
hear
online.
it from Prof Taufik.
Well, so let me just say,
yes, she
this
said
is
they were
not a medical
asking for her organization, and she's not able to log in to follow the link.
Let me just say that I'm not giving any medical opinion during this. So we're just talking in general, because the best person to give an opinion is the doctor that's actually seeing the patient. So they have the full full picture of what is going on. Now, if a patient with cancer is gaining weight and we've ruled out other reasons why they could be gaining weight, it's not like they're retaining fluid because of heart failure or kidney failure or malnutrition, then that could actually be a good sign that the cancer is getting under control in general. So not losing weight for a cancer patient is a positive. Gaining weight, you have to make sure it's not due to other problems. And if you resolve those that it's not due to other problems, then what else could that be? Could it be side effect of the drug? So oftentimes when patient gets cisplatin and pemetrexed, they get a lot of steroid with it. And depending on how they take it, someone can gain weight from that. If you're saying abdominal growth is getting bigger, I'm worried. And like I said, this is not a medical opinion. They will have to talk to their physicians directly. If it's just the abdominal growth that is getting big, but everywhere else they're losing muscle mass and skinning, then you have to make sure that the cancer is actually not spreading to other parts of the body that is causing the abdominal swelling. And then the third is, over what period of time is this happening? Oftentimes when people get diagnosis of cancer, we say if you lose more than 5% of your baseline weight, it's a bad prognostic sign. But if they respond to treatment, so the patient might say they're gaining weight, were they gaining weight and getting back to their baseline? Or are they gaining weight and even going beyond what they were before they were even diagnosed with cancer? So these are some of the nuances that's difficult to tease out, just talking over Zoom, that I will encourage them to just take all these questions back to their physicians to say, why am I gaining weight? Am I retaining fluid? Is this because the treatment is working? Or is it because the cancer is spreading to other parts of the body that we're not, picking up on?
Thank you, sir. Thank you very much, sir. So, sir, from your experience, can you reflect on your experiences with lung cancer diagnosis and treatment in US compared to Nigeria? What do you see as the greatest needs? What is the take-home message for us all to learn to strengthen our health systems to be able to manage
Dr.
this lung cancer?
Dr. Iba, hold on a second. Before it's a take-home message,
okay,
do we have any more questions?
Okay.
Do we have any more questions in the
There are questions in the Q&A.
Please, let's take Q&A questions, please. Yes, let's use questions.
Okay, so maybe should I go through them or are you reading them?
Okay, let's just go. So we have there's somebody we have here is very interesting. We have Benta. Benta is actually from Kenya. And she says, further still, to overcome the misdiagnosis and possible prolonged patients, should we have the pulmonologist at the forefront of the lung MDT and lung patient care?
Yeah. Yeah, I think that is similar to the first question about the MDT.
So she's asking about the role of the pulmonologist.
Yeah, the pulmonologist should be part of that. And, for every MDT, you need to have what we call a quarterback, like a captain, right? On the soccer field, who is the person that is going to coordinate this? Oftentimes, it's either a pulmonologist or a surgeon, because that is the entry point for a lot of patients, at least here. They don't come in through the medical oncologist. Most patients will come either through their pulmonologist or through the surgeon. So having a pulmonologist be the coordinator of that MDT, I think is going to be very helpful, because they can then help you make your diagnosis on time. If you need to obtain biopsies, to stage the patient, all of those things, I think either a pulmonologist or a surgeon being the coordinator of your MDT effort is going to be very helpful. Yes.
The next question says, this is a very interesting and rich conversation. I'd like to know if there is any progress that can also be mentioned regarding lung cancer response in Nigeria. Also, is there anything underway that you are optimistic about? Thank you very much.
So I'm assuming that this person referring to response to treatment, right?
Yes.
Patient response to treatment.
Yes.
I
lung
don't think there's
cancer response.
anything. I don't think there's anything unique, special, or particularly challenging about lung cancer that is diagnosed in the Nigerian versus any other nationality. If you give the right treatment for the right reasons to the right patient, we expect them to respond. Now, having said that, with any type of cancer treatment, response rate is not 100%. But if you match everything well, especially when we're talking about targeted therapy, the response rate in those that could be north of 70, 80%. So I've not seen anything that says if you're a Nigerian or you're Black versus Asian versus this or that, that the treatment is not going to work for you. It all has to do with the biology of the disease in that patient. And that is why it's important to be able to distill down to the molecular level the type of lung cancer that we're treating the patient for, and then give them the right treatment for that. Am I optimistic? Yes, there's always room for optimism. Having this conversation by itself is enough optimism to say that people are recognizing that this is a problem and we want to apply ourselves to it. It's not just lung cancer. I think whatever we learn from this conversation can be taken to other settings, both cancer as well as non-cancer setting, to help patients in the long run. Yes.
I'd like to add something here. Now, 20 years ago in the oncology clinic, all we did was squamous cell, adenocarcinoma, large cell, neuroendocrine, small cell. But now every patient that comes in with lung cancer, I'm beginning to have that conversation where I want to subtype. For me, that's a major step.
Mm-hmm.
We are still struggling with patients being able to afford the medication, yes.
Mm-hmm.
There's a saying in medicine, you recognize only what you know.
Mm-hmm.
So if these conversations were not being had, then my chances or that patient's chances of ever even getting close to optimal care was very slim.
Mm-hmm.
So we are shifting. And the fact that we can have 42 people at 2 p.m. in the afternoon discussing lung cancer, I think is something. We are getting somewhere. It's, drop, we will get there.
Yeah.
So I think we have every right to be optimistic. There's another question we have. It says, thank you for the lectures. Besides cigarette smoking, what are the other causes?
Yeah, this is a very important one for people to be aware of. We've talked about smoking, but I also want to make sure that we recognize that it's not just smoking that can put people at risk. Yeah, majority of patients, that is true. But we now recognize, there are other environmental exposures that could put people at risk. The one that is well characterized is radon. So radon is a gas that leaches from the ground. And depending on the location, now, I don't think we have a radon map in Nigeria for us to know where do you have a lot of radon and where do you not. Here, every county and every state, they have what they call a radon map. So you know what the radon level is for a particular area. And then for each house, once you build the house, they will actually do a radon test to make sure that you do not exceed the level that is considered safe. So knowing that as a risk factor, of course, compared to tobacco, it's like, comparing a mouse to an elephant, but it is still a risk factor that's recognized, and it could also be multiplicative if you are smoking and then you also have radon exposure. The other risk factor could be air pollution in general. There was a recent study out of the UK where they showed that people getting exposed to just particulate matter in the environment, if it's above certain level, actually in animal model, that could induce the development of cancer in the lungs of those animals. And they were able to correlate that with what is going on in the lungs for patients with cancer and those without cancer. Unfortunately, that was actually one study I was planning to do with Dr. Jibrin across Nigeria to look at different regions of the country, because we still do a lot of autopsies. For us to look at lung tissue from people going to autopsy at different ages in different regions and see whether we can see some of these telltale signs of early changes in the lung that could correlate with pollution-induced lung cancer. And then family history is not, lung cancer in general is not something that we say runs in family. And I say that with the caveat that when we say family history, meaning you are predisposed to developing lung cancer regardless of everything else. We should not confuse that to families that do the same type of, they participate in the same risky behavior, and then they come down with the same problem. That is not genetics, that is social behavior. So if the parents smoked and then the children picked up smoking very early, and then the dad gets diagnosed with lung cancer, and then 10 years later the son got diagnosed with lung cancer, yes, that may look like family history of lung cancer, but that does not prove that it is genetic. You have to then show that it is not because of their common social behavior or maybe common exposure to something else. You know, if they live in a region where there's perhaps a lot of environmental pollution and things like that. Other things to be aware of, which are sort of weak, but you know, everywhere you look, diet and alcohol use tend to just increase the risk of cancer development. So I think moderating that and being physically active is also important. And in the context of Nigeria, especially, I know there's a question about the South-South and what is going on there in terms of oil spill. Yeah, you know, at times chemical exposure as well and heavy metal exposure could also predispose to the development of lung cancer.
So that question is from Ronsi Chidebe. He's the executive director of Project Pink Blue. He says, please, I want to ask, we have been seeing so many lung cancer diagnoses from people in South of Nigeria. Could the oil spillage have any role in this? Are there any research around these issues in the Niger Delta area? Thank you so much to all the speakers. So he's asking anything, and he has another question as well. He's talking about, are there evidence from Nigeria that shisha, the flavored tobacco, could be responsible for lung cancer? Are there evidence to show that home heater or air conditioner could lead to lung cancer?
Okay, so I think there's a lot packed into this. So let's take it one by one. You know, I just mentioned the environmental exposure, and I wouldn't go out on a limb and say, oh, oil spillage is causing lung cancer. I'm not saying that. Now, if we have communities where maybe we are beginning to see a lot of clusters of cancer diagnosis, it may not all be cancer, it may not all be lung cancer, it could be other types of cancer. And especially in the South where we know there's a lot of environmental damage, that could be a reason to say we need to study this very carefully. I don't think we just want to jump into, oh, we see 3 people with cancer diagnosis, all of a sudden, oh, oil spillage is causing lung cancer. No, we do not want to do that. That is actually a great disservice. That is not scientific. But I think based on the comment here, if you are beginning to see a lot of people being diagnosed with lung cancer when you were not having that diagnosis before, always ask what can cause this and not what is causing this. Because if you say what is causing it, you're just going to jump to is oil spillage. Is it just because now maybe there's now the capability for people to take biopsies and not assume that everybody is tuberculosis? That could be one reason you want to exclude that. Could it be maybe these are people moving from one area of the country to another area of the country and they could have had some sort of common exposure? You have to exclude that. The third is, you know, oil spillage by itself is not something that any type of environmental exposure is not going to cause cancer overnight. So what population are we looking at? These people have been living in this same area and they've been exposed to this contamination for decades. You know, that can start making you think, okay, perhaps that might have something to do with it. But you know, the reason why we have universities is not just to produce professors, is to help with societal problems like this, then double down on it, and then try to find answers. So I would say that this could be an important project for maybe University of Niger Delta or University of Port Harcourt or any of the other higher institutions of learning there, maybe to partner together and say, we are beginning to see these clusters and then come out in a systematic way to actually contact trace all those diagnoses and see who else in that community is coming down with cancer and who else is dying without a diagnosis, because that is the other thing. Maybe what you are seeing is actually a tip of the iceberg. Maybe there's a lot more going on that you're not seeing. So you may also want to go into those communities and say, well, you have 10 people dying suddenly of chronic illness that you did not have proper diagnosis for. That could be a reason for you to want to promote autopsy, study in people dying at home and things like that. And then, what was the third aspect?
With flavored tobacco.
So shisha, what is that one? I've been out of the country for some time. So is that a special flavor for Nigeria or?
No, it's very common in the Middle East. You know how they have the pipe?
The water pipe.
Yes, with flavored tobacco.
Water pipe. Oh, okay. I thought it was, because when you say flavored tobacco, yeah, we're talking of menthol flavored tobacco, because there's actually a problem with that. When you add menthol to tobacco, it actually causes more addiction to cigarette. But if it's a water pipe, so the story of water pipe is a little bit complicated. The best work in water pipe is actually being done at American University of Beirut. And what they have been able to show is water pipe by itself, if it's just the water that you are vaping in, it can cause some lung damage, but it's not tobacco. Now, it depends on what you now add to it. If you add other additives, that might cause a problem. But the way they look at it is oftentimes when you go into those shisha bars, they also smoke. So it's not just the water pipe alone they're doing. They're doing water pipe, but they're also smoking, whether at the same time or, in the immediate environment of the water pipe bar. So it's a little bit complicated. I would say we look at water pipe as a gateway activity that gets you into smoking, even if you are not planning to smoke. Air conditioners, I don't think anyone has shown any evidence to say that air conditioner will cause lung cancer. And what was the last one?
The heaters, home heaters.
Home heaters, same thing. There's no evidence to suggest that is the cause of lung cancer.
Okay, so we have another question. This is a different one. This one says, do you have any time planning to come to Nigeria to set up your own facility to alleviate pains people are facing as a result of brain cancer existing in our communities? Thank you.
That's okay. So I think the immediate answer, I do not have any plan to come and set up any facility. I think that one is sort of easy to answer. But that does not mean that I do not want to be part of the solution. So part of doing this is, giving back to the society in whatever way, shape, or form we all can. It doesn't mean that you have to come in and set up a facility to duplicate what people are already doing. The problem in Nigeria is not because we are lacking one facility that I have not opened that's now going to solve the problem. I think it's more about being intentional, strategic, and coordinated in our approach to solving these problems.
Thank you, sir. Another question says, thank you so much for the lectures. I want to ask, what's the risk relationship of firewood smoke and lung cancer?
Okay. Now, this is where I have to be careful because I don't want this to now become Dr. Wonigoko said firewood causes cancer, so don't use firewood. So, I don't know, is that from a patient advocate or from a physician? So I just want to know.
It doesn't say. Abdul Majid Jibril Maina. It doesn't say.
All right. So, in the beginning, I talked about lung cancer in never smokers being the fastest rising subset of lung cancer. And I said about 40% of patients in China and India will actually have that form of non-tobacco associated lung cancer. That is true, but we've not answered the question why. So why are people developing this lung cancer if they didn't smoke? What is the reason? Why are they developing it? So one of the theories now is not proven. We have to prove it before we can go out there and say that is what is causing it. But what one of the theories being explored is actually open flame cooking. It's not the firewood, but what you are cooking, right? And that when you do open flame cooking, which is very common in Asia, as you know, you go to Chinese restaurant, the flame is now they use gas, but if you go back in time, it will be firewood and everything else that is burning, and you have all this micro particulate matter that is being released, and people are inhaling it. In addition to whatever you are cooking, that is also becoming flammable, and then maybe you are inhaling it. Because part of the reason why people started thinking about that had to do with when we look at these non-tobacco associated lung cancer, they tend to be commoner in women. Even in India and in China, it's like, what do they do that the men don't do, right? One of those is cooking. They are more likely to be the ones doing the cooking than men. So that was actually where that theory started coming up. Now, I mentioned to you the study that I said was published about 2 years ago from the UK, where they showed that microparticulate pollutant in the environment can cause lung cancer. That is actually linking those two things to say the microparticles that you release during open flame cooking, you can inhale it. And if that is chronic, maybe over time, that can cause enough damage and inflammation in the lungs that would then result in lung cancer. That is not proven. It's still a theory, but it's something that people are beginning to think about. So that's why I don't want people to go out and say, oh, open flame cooking or, firewood cooking causes lung cancer. Don't do it. And but I think it's something that we have to continue to pay attention to.
So while we're talking about having the conversation of the non-proven, there's something that's been proven I'd like you to throw some light on. Secondhand smoking.
Yes.
How
So
serious?
secondhand smoking is proven to be almost as bad as first-hand smoking. So second-hand smoking, what we mean by that, for those who may not be conversant with that terminology, is you don't smoke, but you are in close proximity on a regular basis to those who smoke, and then you are exposed to their tobacco smoke. So even though you don't have the cigarette to your lips, but you have the smoke in the environment and you are inhaling that, is just as almost as bad as you doing the smoking yourself. Now, there's also now the concept of third-hand smoking, which is somebody smoked in an enclosed area. They left. You never met them. Now you came in after them and you stayed in that space. So this tobacco smoke that they left behind that was trapped, now you are smoking it. You are inhaling it. So that is third-hand smoking. That has not been shown to be as bad as second-hand smoking, but people are beginning to look at that. And that is why now, in a lot of countries, they are banning smoking in public spaces because of all this concern about second and third-hand smoking. But that is a risk factor that we know can predispose someone to lung cancer. So if somebody tells you, I don't smoke, the next question is always, do you live with somebody who smokes on a regular basis? If your husband smokes but you don't smoke, but you're in the same house, you are a smoker, technically, because you cannot avoid that. Or if the parents smoke and the kids are always at home, then they're getting exposed to the same deleterious effect of smoking, even though they're not the ones doing the smoking.
Thank you, Prof. We have another question that says, what can we do as players in this space to have a harmonized approach as to identifying, diagnosing, and treating lung cancer in centers across Nigeria? I think this is from a pharmacist in one of the pharmaceutical companies. They're asking what can they do from the pharma perspective to help harmonize the approach to identifying, diagnosing, and treating. Well,
yeah, so I think, and this can sound simplistic, but you have to start from somewhere. It's very easy to just say everything has to be the best everywhere. Realistically, that is not going to happen. Even in the best of places, you still have to, uh, tailor your effort to where you can have maximum impact. I think one strategy that potentially could be adopted, and looking at people in the audience, you all have positions of authority, if not direct authority, at least leverage within whatever organization you work in, would be to start selling the idea of, are there locations across the country where you have critical mass of people coming together, and maybe whether it's at the ministry level or maybe a partnership between the ministry and some of the key stakeholders, where you can come up with minimum required standard of, say, if you want to deliver lung cancer care, these are the things that we feel you need. And if you meet those standards, then you can give them recognition that, okay, this is a center of excellence or emerging excellence or center of expertise, if you don't want to use excellence, right? So that people at least know, okay, if I go to so hospital in Abuja, they've met this requirement and they are expected to perform at the top of the line when it comes to lung cancer care delivery. And you will have to look at what is the best practice out there around the world. It's not that you want to sort of just do things for somebody to have a plaque and show it on the wall. To say, okay, these are the best practices worldwide. If you want to strive and meet this standard for your own location, then we're going to go through the process, evaluate it independently, and then start from there. And what that would do is, human beings are competitive by nature. If you do it right and you do it objectively, it doesn't become, oh, this is my friend, I need to get them a plaque. That's not going to work. Everybody will have to agree. It has to be an objective process. You have to meet certain standard. Then those who do not have it, they will strive for it. And that would, over time, elevate the practice everywhere. But you will have to start from somewhere. So that, I would say, that could be a very simplistic approach to doing this. The other is partnership, right? Nowhere is an island. Even here, we also partner amongst ourselves. One institution might have something that we feel is better than what we have, and we partner with them to learn from them. And vice versa, they can come to us and say, oh, you guys are really doing really well in this. We want to learn how you do it. So being open, being generous, and being willing to share, I think, will go a long way to elevating the care that we provide to patients.
Thank you, Prof. So you're talking about, so what I've gotten from what you've just said is we should make sure we have guidelines on lung cancer management.
Mm-hmm.
Includes diagnosis and treatment. And
Yeah.
then have those centers that will be kind of like licensed to treat lung cancer. And they have to follow those guidelines.
I wouldn't say licensed to treat lung. I'm just saying they will be recognized.
Recognized.
Having, special expertise in doing it.
So,
somebody can decide, I can't afford it. I will just go to my, my regular facility.
By government to be given, I think so. These are things that we need to go back to our policymakers, the advocates, and put it together so that people are now beginning, because we did it in breast, we did it in cervical cancer, and patients now know to go to certain hospitals. So I think that's a good way to go. We have another question from Ron C. He says, my possible last question. Navigating patients with lung cancer is almost non-existent because of the stigma with lung cancer in Nigeria. Are there strategies that you could share on patient navigation program or ideas that in the United States?
Yeah. So patient navigation is a very useful tool to have, but it's also an expensive tool if not done properly. because most places, as you know, Nigeria inclusive, people always ask, okay, if I do this, what do I get in return? If I make this investment, what does that translate to in, if you pay for something and they do surgery, you say, okay, this is how much you're going to charge for it. Navigation, there is really no obvious return on investment that you can calculate and say, okay, we spent 50,000 naira on the navigator and then see how much came back in. You don't have that linkage. So that's always made it possible to justify to systems the value of navigation. But how you can show that to your system is actually patient outcome and patient evaluation of the care that they receive. We know that most patients, if they have adequate navigation support, even if they get the same level of care, but the ease of navigating them through the various stages of their care gives them that sense of being better taken care of. So there is that benefit of navigation that you cannot quantify in dollars and cents or naira and kobo. Now, who gets to pay for it, right? In a system where even for things that you can immediately show return on investment, you struggle to get paid for it, how do you now get navigation to get paid for? I know people are becoming more generous and philanthropic minded in Nigeria. A lot of places here, navigation is actually through philanthropy. It could be a patient who has gone through a similar experience, like, oh, I really had a tough time going through this. This should not be this difficult. And they might, decide to support the navigation effort for your facility. But that is one-offs. You really cannot just rely on people's sense of generosity to provide navigation. I would say it has to start at the unit level, meaning the hospital or the center, wherever you practice, where you have to demonstrate some value that navigation brings, and especially from patient perspective, to show them how having that navigation helps patients. Now, this is navigation in the hospital. There's also a lot of navigation to be done in the community. And that may just be as impactful as what you do in the hospital, because oftentimes patients are, when they are in the doctor's office, they're intimidated, confused, they can't remember what they wanted to ask. And then when they get back home, they say, oh, I forgot to ask about this. Oh, what was I supposed to do about this? And things like that. So actually having that community-based navigation is also going to help patients. But to me, I think given where we are as a society, that is probably asking for too much now. If you're thinking of community-based navigation, I would say perhaps having some type of navigation within the facilities would be the way to go and where to start from.
It's a good thing someone is asking. Coincidentally, National Hospital has a patient navigation. It's in collaboration with the Beacon initiative from ACS. So we launched it about a year ago. And just like you said, it's difficult to justify because there's no result. But the patients definitely love the navigators. And from our last minute meeting, we talked about us getting their feedback as something to encourage the management to help with, supporting it. But patient navigation is something that I think anybody who is managing cancer patients should try to, have. Like Freeman said, nobody should be caught up in the process of, cancer treatment. They already have enough to deal with.
Yeah.
So patient navigation is, and even though, like you said, community navigation is, too high for us to reach for. Patient navigation has done wonderful things for us, and I hope we're able to sustain it, because financing it has been will be difficult as time goes. We have another question where they're talking about coal and charcoal. I believe you've already answered that indirectly from the other question. Osabohe Matthew Oko is talking about thanking us for asking about the second-hand as well as third-hand smoking. So I think that has been answered. And then we have a colleague of mine, Dr. Wachuku. She says, thank you, Prof. This has been really enlightening. With the rising incidence of diagnosis among never smokers, Okay. I believe we may miss a significant group if we screen based on smoking history. What can we do to participate in lung cancer clinical trials to broaden our treatment options for lung cancer? Okay, so she's asking, because one is a comment, talking about screening on the never smokers group. We haven't even gotten to the screening yet, but let me allow Prof take that, because we talked about that earlier. And then she's asking about, getting involved in lung cancer clinical trials.
Yeah. So I think, we talked about screening and the challenges with screening. Population-based screening is very challenging. It's resource intensive. So you have to focus on where you're likely to have maximum impact. That is the reason why, even for the approved low dose CT screening, we're not just saying, go and screen everybody that ever smoked. No, we are limiting that to those where we think the risk is highest, so that you minimize the burden of heart population to screen, right? And you also minimize the problem of having to follow false leads. Because if the pre-test probability of you having lung cancer is low, whatever you find during that screening is probably going to be negative. But then you find it, you have to work it out. So that would add to the expense. So thinking about patients who are never smokers developing lung cancer. So how do you screen for those patients, right? Without saying everybody and their uncles and nieces should be screened. So people are beginning to look at how can you better target that population of patients or at-risk population for screening. There are now efforts being made, especially in Korea, China, I think Japan as well, where they're beginning to stand up low-dose CT screening for never smokers who have certain characteristics. One is they must have an immediate family member diagnosed with lung cancer at a relatively young age, less than 40 years of age, and they must not be smokers. So those are the two things that they're trying to use to sort of narrow the population of patients that you want to screen. I think in Nigeria, for you to do that, you really need to, number one, know who are those patients. And actually, just this week, there was a publication in Lancet Respiratory Europe region, or whatever it's called. It's one of the Lancet journal daughter papers, where for the first time they were able to characterize lung cancer diagnosis in the UK, specifically in England. And they went through about 17.5 million people, record of 17.5 million people over about a decade or so. And they were able to show that the highest incidence of lung cancer in England was actually in Bangladeshi. The never smokers, they tend to be more Caribbean and Black Africans, which I think if you're thinking of England, is probably mostly Nigerians and Ghanaians. And if you look at that population there in the UK, about 35.5% of them, if I remember correctly, about 35% of those patients of Black African ancestry actually had lung cancer in never smokers. There are never smokers who develop lung cancer. So it's not something that does not exist in our society, because those are first generation immigrants. I don't think it's something that just happened to them because they were in England. I think whatever predisposed them to that probably has something to do with the people that they left behind at home as well. The only problem is they have the data to be able to go back and answer those questions. We have to generate similar level of granular data in Nigeria to be able to contribute to that body of knowledge.
She asked, what can we do to participate in lung cancer clinical trials?
Oh, so in terms of trials, I think you have to think of trials in different buckets. If you do not have the history, it's almost a situation of the haves will continue to have and the have-nots, probably never. So you have to sort of figure out a way to break that cycle. One way to think about that is, what type of trial can you do local to demonstrate proficiency in doing clinical trial? If you look at a place like India, for instance, 10, 20 years ago, nobody was going to India for trials, at least from the West. So we want to take our trial to India. But then they started developing local interest and expertise, and they started doing their own trials that are relevant to their population. It's not just waiting for somebody to say, oh, we have this new drug we are looking for, where to test it, do you want to be part of it? They were asking questions relevant to their population, and then started showing that they have that expertise. They collaborate with other centers, and mostly through diaspora Indians. And then over time, they develop that in-country capability that now, not only are they doing their own trials, but they're also now getting global trials coming into India. I think the same approach will have to be adopted in Nigeria, just like we're describing, maybe having centers where we know we have unique expertise in taking care of specific patient population. That would also be things that people will have to explore. I know that the NSIA Cancer Center, they're trying to develop that expertise in Lagos for them to be able to offer clinical trials to patients. There are some private cancer centers as well there in Lagos that I'm aware of. But even in Abuja, there are facilities that have been participating in other types of clinical trials, not cancer trials, but maybe HIV and other types of infectious disease trials. So those are opportunities that could be further explored and then expanded to then develop that in-country capability to participate in lung cancer and other cancer clinical trials.
Thank you very much, Prof. We've had a long day, and I know if we stay on, we will keep on. I'm wondering if Prof has had his breakfast this morning. We've had such a beautiful day, and I know if we stay on, the questions won't stop. Prof, we want to thank you so much we've spent almost 2 hours, just talking and talking. But there are two things I would like to ask. One, are you going to be in Accra for the Pan-African Lung Cancer meeting? You're going to be there?
Yes.
Oh, perfect. Because I know quite a few people who are in the house will be there. Hopefully we'll get to meet you, and we'll talk more, and we will discuss possible things we can do in the lung cancer space in Nigeria. The second thing is to say, Prof, please, it's a small group. Lung cancer is not as established as breast cancer. We will be reaching out to you in the near future, and to either be personally when we have a patient that we need, your expertise on, or for programs like this. We've had a lovely afternoon, and I'm just so honored. Being in oncology space, I'm not too sure if the people understand what a big deal it is to have someone of your caliber. Spend 2 hours of your time just taking us through, this topic. And, we're really, really honored, and we're really thankful on behalf of NMA, FCT, and all the other participants. I would like to say thank you very much, and wish everybody a good afternoon. I'm quickly trying to round up because I really don't want us to keep people longer than we're supposed to have closed 15 minutes ago. But just before I say goodbye, is there anybody who would like to quickly say something, wants to ask a question quickly? Because you will not find Prof easily, again. Let's see if there's anybody who has anything they want to say quickly. I don't think so. At this point, I would also like to thank MACA, because MACA was the one who made the connection with you. I know we have their representative here online. Caleb, we are very grateful. Lung cancer is a forgotten space, and you are really making it come alive. You are making us have those conversations. National Hospital has a lung cancer MDT. We're not as active as I would like. Courtesy of the meeting in San Diego, I became an advocate for lung cancer, and we're beginning to have these conversations, and I'm really beginning to feel there's it's not as hopeless as it used to sound. And I thank you for that, Caleb. I really thank you for making sure we're having these conversations, and we're beginning to, you won't be able to do that magic at once, like Prof has said, but let's reach out for the low-hanging fruits. Let's try to make the diagnosis make it early, not keep patients, waiting. Try to standardize our treatment or our diagnosis and treatment in at least the tertiary hospitals. Let's keep on encouraging each other. Thank you very much, everyone, and have a wonderful afternoon and lovely weekend. Thank you, sir.
Thank you so much. Thanks for having me.